When I was a kid, my parents would take me to a children's museum where they had a model of a cow that you could milk. This cow had a window in its side so you could see its fake organs and you could see how its stomachs worked. I loved this cow. I loved being able to see the inner workings of something I could never usually see. When I'm having cramps, I wish I had a cow window into my own belly so I could see what the hell is going on in there. Does my uterus look different when it's cramping? Would it be possible to see the prostaglandins when they start spreading to my stomach or my intestines? When I get shooting pains into my lower back, what does that look like? What's going on in there? Unfortunately, they do not make cow windows for people, as far as I'm aware. The closest things we have are the ultrasounds and MRI machines that doctors and researchers use to get a little peek at what our bodies are doing. Last episode, we laid out some of the reasons why not much research has been done on women's bodies compared to men's bodies. This week, we're talking to the people who are doing that research right now and asking them what they see through that cow window. Okay, I'm gonna stop saying cow window now.
What's happening to your body, we don't know, because we've never really studied the female body. Say it's all in my head, but the research is quite spotty. No, we've never really studied the female body. I go to the doctor to get dismissed. Try losing weight, you're just anxious. That's fine, math's cool, I'm not pissed. Just wait 10 years for a diagnosis. Psychosomatic, you're so dramatic. Hysterical, emotional, hormonal, erratic. Heart disease, chronic fatigue, depression and anxiety. Do you have pain? No, you don't, because we've never really studied the female body.
If you start looking up medical papers about dysmenorrhea, like I have for the last few months, you'll come across two names over and over again: Dr. Kevin Hellman and Dr. Frank Tu. Combined, they have published over 100 research papers about dysmenorrhea alone. If you read almost any article written in the last 10 years about dysmenorrhea, they are quoted. When I looked them up, I discovered that together, they run the Gynecological Research Lab, or the GYRL, or GIRL, I guess, out of Endeavor Health's North Shore Evanston Hospital. The URL for the GYRL, insane sentence to say, is cureperiodpain.org, so I knew I was barking up the right tree. After successfully convincing them over email and a Zoom call that I was, in fact, a real podcast producer who was really doing a podcast about the search for answers about period pain, they agreed to let me come to the lab for a day. The GYRL lab is working on a bunch of different research projects at the same time, and these are fundamental questions they're trying to answer. Questions as basic as, what makes cramps hurt? So obviously, I flew to Chicago and got my ass to their hospital. I sat down with Dr. Hellman in a hospital meeting room. Dr. Hellman, to the best of our knowledge so far, can you explain the causes of primary dysmenorrhea?
Sure. So let me give a bit of a historical background. Our insight on what causes menstrual pain in the past had been largely based on people that put intrauterine pressure transducers. So basically, it's something that measures pressure, and they put it past the woman's cervix into their uterus. So early work by Woodbury in 1947 suggested that women with dysmenorrhea were more likely to have uterine contractions or higher pressure contractions. And at that time, they conjectured, well, that uterus can't possibly be well perfused or oxygenated.
Perfusion means how much blood is getting to something. So well perfused means plenty of blood flow, which brings oxygen that muscles and tissue need to function and stay alive. We talked a few episodes ago about ischemia, which is what happens when blood isn't flowing to a muscle or a tissue. And it usually causes severe pain because the muscle is warning you that it will die if it doesn't get more blood flow.
So that work in 1947 led to the idea that maybe uterine contractions and maybe lack of perfusion or oxygenation is responsible for menstrual pain. At the same time, people believed in this myth called menotoxin, that there was something toxic in menstrual effluent that could kill plants.
Another quick definition here, effluent is the stuff that comes out of the uterus during menstruation. We think of it as period blood, but there's other stuff in there too, and that stuff might help us understand period pain better if we stopped thinking it was so gross. And yes, there did used to be a scientific belief that period blood had something called menotoxin in it, and that plants could die just from being touched by a woman who was on her period. And this wasn't in the Middle Ages. Well into the 1950s, there were scientific papers being published about how period blood can kill plants and animals. Just another reason that it's hard to talk openly about our periods.
So, believe it or not, that myth was in some ways very useful because people started to say, well, what is it in the effluent that can kill the plants? And around 1970s, the discovery of prostaglandin, there was a huge convention in Norway, and Dr. Chan, Dr. DeWood, they had characterized prostaglandin, and it was observed to be higher in people with menstrual pain.
Cut to around 50 years later, and the GYRL lab took that research even further.
We set out to figure out what is really going on in women while they're experiencing menstrual pain. We started off with ultrasonography. One of the key differences in our studies is we had a woman squeeze a bulb every time they experienced a cramp. So we could start to link what is occurring when a person is experiencing cramping pain to what we see. And in brief, what we saw was not just something in the uterus. Women experiencing menstrual pain had skeletal abdominal muscle activity that preceded their pain. So what we think is occurring in some women, they have a visceral motor reflex. So something occurs in their uterus and they have a guarding reflex. Their abdominal muscle contracts strongly. And if you can imagine, having one of these basically stomach crunches every couple of minutes for a couple of days, that could cause a lot of just pain alone. And what our studies suggest is it's not just about contractions. There's a widespread belief that ischemia might be responsible for menstrual pain. But our studies suggest even though there is a reduction in perfusion and oxygenation on a woman's period, people with menstrual pain, if anything, have better perfusion and better oxygenation than pain-free controls.
Wait, so what Dr. Hellman just casually walked me through is that everything I thought I'd learned about why cramps hurt, prostaglandins causing uterine muscle contractions that restrict blood flow to the muscle, which causes ischemia and pain, that might actually not be what's happening. That's not what they're seeing when they put women experiencing cramps into an MRI. What?
There's got to be something more than prostaglandins. And certainly it's not just about ischemia, because in fact, when you give women NSAIDs, if anything, their uterus, at least the people with dysmenorrhea, their perfusion and oxygenation gets worse. So if you were to think, if you were just to restore the perfusion or oxygenation, that would solve their pain, well, that's not what we see. So our hypotheses about perfusion and oxygenation, contractions, and prostaglandin might need to be revised.
Again, Dr. Hellman just casually pointing out that everything we thought we knew about cramps is incorrect. We might not even know why NSAIDs like ibuprofen tend to ease the pain of cramps. I've always thought of the pain from my cramps as pretty straightforward. Something physical is happening in my body that is causing me pain. But it turns out menstrual pain is not as simple as cause and effect. Why do I sometimes have regular cramps and sometimes I have death cramps when theoretically the same thing is happening in my body? Do we know?
So the answer is really no, but I can explain why we don't know.
Okay, great.
And I should point out, the whole cramping pain experience varies so much from woman to woman. Some women actually don't have any cramping pain at all. They have constant pain. Some people, we call them short squeezers. We put them in an MRI facility and they squeeze a bulb every time they have a cramp. Their squeezes only last about 5 to 10 seconds. The uterine contractions last about 70 seconds.
Wow.
So raises an interesting question. What are they responding to? Some people, it seems that their cramp pain is at the beginning of these contractile events. Some people, it's delayed. It's towards the end of a contraction, suggesting maybe it's reperfusion, when you have additional blood flow coming back into the uterus. These are areas where we're currently studying, but they definitely deserve more research.
The GYRL lab is finding that the pain of dysmenorrhea is showing up in ways that I hadn't considered at all. And I've considered a lot of the ways that the pain of dysmenorrhea shows up.
You can ask people how much their bladder hurts when they drink water and their bladder is full. And people with menstrual pain are more likely to report that their bladder hurts when it's full.
While they're having menstrual pain or at all times?
Off their period, so at all times. So there's a general idea that people with menstrual pain have more visceral organ sensitivity. So one reason why some people might have menstrual pain and other people don't is their uteruses or their brain circuitry are wired such they are more sensitive to uterine pain. So they're very powerful brain pathways that can produce pain relief that we still fully don't understand. And if we probably understood these pathways, we may not only be able to answer why do we have period pain variability, but even help people that experience not just menstrual pain, but other forms of pain.
Wow, okay, that's wild. You have done a couple of studies looking at NSAID-resistant dysmenorrhea. One of these studies I read said around 18% of the populations you looked at with dysmenorrhea were NSAID-resistant, meaning like ibuprofen does not help, they are still in pain. What could cause that?
Well, in one of our papers, we showed that they weren't even absorbing the NSAID at all. So we brought them into the lab and we were doing one of these ultrasound or MRI studies. We gave them the drug, we saw them swallow it, and then we did a blood draw 90 minutes later and nothing there.
Really?
There was literally nothing there or very little low levels of the absorbed dose of naproxen sodium. So one hypothesis is some people are not even absorbing it. Their GI system may not be functioning the same. So absorption is one possible reason. You also have to get the naproxen all the way down to the uterus. So you have a question of distribution. We don't know for sure that all menstrual pain is of uterine origin. I mentioned before that it could be an abdominal muscle event, and certainly in some people, it's probably intestinal.
Okay, Dr. Hellman has just blown my mind multiple times in a short conversation. Let's take a little break to pick up the pieces of our minds with something we understand. Ads. When we come back, we're going to talk to a couple of other researchers who are also discovering new things about menstrual pain.
Cause we never really studied the female body.
Welcome back to CRAMPED. We've been talking to Dr. Kevin Hellman, who is one of the directors at the GYRL lab outside of Chicago. The team has been looking into some basic questions, like what causes period pain? And what they're finding is that the currently accepted theories of prostaglandins causing muscle cramping, which causes ischemia, which causes pain, are wrong. Or at least that isn't the only thing causing the pain. Now, the GYRL lab isn't the only period pain research game in town, and there are other researchers spread across the country looking into other aspects of period pain. But it's a small club. Dr. Hellman pretty much knows them all, and he was kind enough to put me in touch with some of them. First, let's meet someone researching period pain from an entirely different angle.
I am Dr. Chen Chen. I'm a professor at University of Arizona College of Nursing. I study menstrual pain. Dysmenorrhea is a very complex problem. For my current research, we're looking at mechanism of menstrual pain.
Mechanism is science for what's causing this pain. Researchers looking into the mechanisms of menstrual pain are looking at the cause and effect, trying to find what the people with dysmenorrhea have in common and what makes them different from people who don't have pain.
Yeah, for the mechanism work, this is like a big puzzle with multiple pieces. So one piece of puzzle we're looking at is the vaginal microbiome mechanism.
Vaginal microbiome is exactly what it sounds like. All the teeny tiny microscopic creatures that live inside your vagina. It's a whole ecosystem in there. Bacteria that keep your pH balanced or throw it off, protect you from outside bacteria or viruses, all these functions that we never notice unless they go wrong. So how is this tiny ecosystem connected to period pain?
We found people who have more severe menstrual pain, they are more likely to have bacteria that are more like pro-inflammatory. and they're less likely to have bacteria that are considered like protective.
So you're finding that there's a link between those bacteria that are related to inflammation and more menstrual pain symptoms, but we don't know if they're causing those symptoms or if they're caused by the symptoms.
Right. For that small study, it's like descriptive, and we only look at data from 20 participants. So currently we're doing larger studies, try to better tease out the exact pathway, like how vaginal microbiome composition may play a role in menstrual pain. After that, obviously the next step is more like testing different treatments. If we confirm that vaginal microbiome play an important role, especially probably for a subgroup of people, we can develop intervention that can modulate vaginal microbiome. So microbiome is different from, let's say, like genome, right? It can be modified by different intervention like medications and like behavioral interventions. So that can be a logical next step.
My first reaction to hearing that bacteria living in my vagina might be affecting how much my cramps hurt is, what? Ew. But when I thought about it for a second, it's really the same as the gut microbiome. There's a lot of bacteria living in our gut, and some of them are necessary, and we can't live without them, and they make it possible to digest things and function properly. And then some bacteria can grow out of control and give you horrible gas and diarrhea and stomach pain. Why wouldn't it be the same for a different location in your body? After our interview, I stumbled on another paper that Dr. Chen had published a few years ago about categorizing dysmenorrhea into 3 different types: mild localized pain, severe localized pain, and multiple severe symptoms. In this paper, Dr. Chen argues that having only one term for dysmenorrhea leads to patients getting grouped together and treated the same, when they actually have very different symptoms and severity. And I agree. I wish when I was 14, I could have had multiple severe symptom dysmenorrhea written in my chart instead of just dysmenorrhea. Multiple severe symptoms leads to important questions like, what kind of symptoms and how severe, that just plain dysmenorrhea doesn't invite. I also learned from this paper that vomiting is one of the rarest symptoms of dysmenorrhea, with only 7% of study participants reporting it. Lucky me, one of the 7%. Next, I talked to a researcher who discovered an unexpected way to treat period pain. We love that.
My name is Laura Payne. I am a researcher at McLean Hospital and Harvard Medical School. My research focuses primarily on menstrual pain and the transition from menstrual pain to chronic pain, particularly in adolescent girls.
And you're also a psychologist, yes?
Yes.
So how does that factor into the research that you're doing on menstrual pain?
Well, part of my research was developing a group treatment for menstrual pain, but my research is really focusing on the role of the brain and the central nervous system.
Can you tell me more about this group therapy that you developed for menstrual pain? Because that's not something that you usually think can be effective with group therapy.
We use all different types of cognitive behavioral mind-body approaches for chronic pain. And so I was thinking, why couldn't we do the same thing with menstrual pain? So I developed this 5-session group treatment protocol that incorporated psychoeducation about the menstrual cycle and about pain. We did some basically cognitive restructuring or cognitive challenging. We did mindfulness and a whole session on different ways of coping with pain. And we really focused on delivering some very basic skills, but they could be very helpful during the time of menstruation and menstrual pain for these young women. And the research did show that they experienced a significant reduction in menstrual pain even up to a year after the group ended. Those are all strategies that help reduce fear and that feeling of isolation, which our brains don't like that feeling. And so they're going to signal more pain when we feel that way. The research is ongoing, but we also have to find other ways of helping teens and young women and adult women manage pain and cope with pain and reduce pain that is not just the nonsteroidal anti-inflammatory drugs.
First, and most importantly, let's give Dr. Payne the award for most on-the-nose name for someone studying dysmenorrhea. And I hope she has a band, because I would 100% go see a punk band called Dr. Payne and the Brainwaves or something. It's very cool to have scientific data backing up that feeling I had when I finally found other people who got death cramps and we talked about it. talking about your pain with other people who also experience it just on its own lessens your pain. Having your pain legitimized, recognized, and knowing you're not alone makes it literally hurt less. Brains are so cool. If you're listening to this podcast and you yourself don't experience period pain, but you have a loved one who does, this should be the best piece of research we've covered yet for you. You may feel helpless when someone you love is in pain and there's nothing you can do about it, but the science tells us that just by validating their pain and supporting them, you are literally lessening their pain. I mean, not enough. You haven't solved the problem. Let's not get carried away. But you are helping. Let's take a little brain break. This is a lot of science. You're doing great.
Period cramps. I'm late again. Zoom calls at 10. Put on my pants and turn on the camera. What's your workout? You look so great. 200 grams of pasta, finish the plate.
That was Period Cramps by Axolotl. And speaking of which, the pain of period cramps isn't coming where science thought it came from. We don't actually know exactly what's causing it yet. And the causes are probably going to be different in different people. But regardless of what's causing it, up to a quarter of people experiencing severe period pain do not respond to NSAIDs like ibuprofen. And NSAIDs and hormonal birth control are pretty much the only options we're given. So if those don't work for us, what else is out there? When I asked researchers and doctors this question, their answers started off normal and got progressively more mad scientist sounding. In the realm of normal, we've got centrally acting muscle relaxants. Dr. Frank Tu co-directs the GYRL lab with Dr. Kevin Hellman, and he also runs a pelvic pain clinic out of the North Shore Evanston Hospital. He says he prescribes muscle relaxants off-label to his severe dysmenorrhea patients pretty frequently, and he has many patients who find them phenomenally effective in relieving their pain. And personally, I can relate. Remember that urgent care visit for never-ending death cramps, where they gave me an IV muscle relaxant? That worked great. But for some reason, doctors in the US don't prescribe them for period pain very often. Another possible option for treatment is something called a neuromodulator, a kind of drug typically used to prevent migraines and seizures. I'll be honest, this one I don't totally understand, but it seems to have something to do with disrupting the nerve pathways that the pain travels on. If you get bad period pain and also struggle with menstrual migraines, this might be something you should research and bring that research to your doctor. This next one really threw me, though. There was a recent small French study that injected botulinum toxin, so Botox, directly into the uterine muscle of 30 people who experienced severe period pain. And it was apparently very effective and improved participants' quality of life significantly. Okay, yes, this is what I'm talking about. I want that weird, out-of-the-box thinking when it comes to figuring out potential treatments for period pain. Would I sign up to get Botox injected into my uterus? Honestly, yeah, I probably would if it had a shot at making my cramps bearable. I also asked Dr. Chen about new treatments. How long do you think it will be until there is another way to treat menstrual pain that isn't just NSAIDs or birth control?
This is a big puzzle to solve. There's definitely a strong need for funding. There are not many teams that actively study dysmenorrhea. As I talk with other researchers actively studying this topic, we all experience rejection because people still have certain perception about menstrual pain. They don't think this is an important topic to be published or to be funded. So I think there's a strong need to increase the visibility and appreciation of the importance of this topic. I think by doing that, we can have better funded research that generates important insight to improve menstrual pain, and so we can speed up the discovery.
The more research that is being done into the various aspects of period pain, the sooner we can have these different, possibly more effective treatments. But getting the research funded is an uphill battle. Severe dysmenorrhea doesn't have the PR behind it that something like cancer does. If we're having trouble talking to each other about our period pain, even one-on-one, of course we're not organizing the kinds of awareness-raising campaigns that help get the research funded. There are no foundations raising money for dysmenorrhea research. So researchers are entirely dependent on the NIH for funding. And unfortunately, many reviewers who make the decision on what proposals get funded don't think dysmenorrhea is a priority. They may believe, as many doctors do, that dysmenorrhea is a solved problem. It's prostaglandins and ischemia, and if you take ibuprofen, problem solved. Since there are barely any representations of severe period pain in film and TV, people who don't experience it themselves may have no idea it's even a problem for people. And look, I'm not saying dysmenorrhea research is more important than cancer research. Not at all. But as I think we've proved over and over again on this podcast, this kind of period pain affects more people than we ever thought it did. And it affects quality of life in a huge, ongoing way for years and years of people's lives. So for many reasons, the awareness is just not there. Not to mention the recent chaos with executive orders from the Trump administration, which has caused $1.5 billion in NIH funds to be delayed, basically grinding a lot of research to a halt. So it's not easy to get funding for this research. But these are very smart people doing work they know is important. And if there's one thing I know, it's that smart people who are locked into a purpose will simply find a way to get it done. And it doesn't hurt when they're fun to hang out with. After we finished the official interview, Dr. Hellman invited me to have lunch with some of the team. About 6 of us. Me, Dr. Hellman, a few grad students, and a researcher headed to the hospital cafeteria. We grabbed our sandwiches or buffet food, and we sat at a table in the busy dining area, which was somehow decorated exactly the same as my college dining hall in 2006. The grad students, 2 women, were shy and polite at first, but as soon as I made it clear that I was totally willing to talk about dysmenorrhea over food, they started asking questions about the podcast and about my symptoms.
When you have more pain and eat less flow.
Yeah.
Do you notice cramping when that happens?
They started bringing up recent papers that they'd read and asking each other about what they meant in a part of the conversation that went way over my head.
I did not see that paper. What did Pareka show?
The title, I think, is Primary Nociceptors Are Functionally Male or Female.
As the lunch went on and conversation opened up, we were just 6 people with a lot of different areas of knowledge, all intensely interested in things that have not yet been well studied. Wait, you were talking about scarless healing.
It's the only example.
Yes, there's this lab in Long Island that I think that is using effluent to figure out what is how do.
I know it's crazy that we haven't looked for just other medical purposes.
They take their work very seriously, but they also have a sense of humor about it, and they understand how weird their work looks to people outside the lab. Dr. Hellman really loosened up over lunch, and I could see the absolute delight and joy he had in his research and his team. And he definitely was not above some light teasing.
Chandru is also the world's expert at menstruing effluent volume.
Yeah.
There's nobody that has measured as much effluent as Chandru.
I love it.
Because he takes pads and tampons.
Yes.
And he weighs them.
In maybe my favorite moment from this lunch, Dr. Hellman put his laptop out on the table to show me a video of an MRI just in and among the sandwich wrappers and disposable cups.
The whole uterus is moving. Just because they have that doesn't mean they have earth-shattering pain.
Right.
You know what the funny thing is? So I'm there for almost every single scan.
Yeah.
I can't tell you even by looking at their face whether they're in severe pain or not. And I was like, you just threw up on the subway. You know, like, I had no idea. She looked fine to me.
Right.
You can't tell by looking at them. You can't tell by their MRI. We have so much to learn.
I don't know why, but hearing one of the most published experts in period cramp pain casually say over a mediocre cafeteria sandwich that even he can't tell at all whether someone is in extreme pain or no pain from their cramps by looking at their face or with an MRI, I don't know, that's just incredibly validating. I learned just as much, maybe more, in this lunchtime conversation than during the official interview. Anytime Dr. Hellman said, "the other weird thing," I got excited.
The other weird thing is, you see the bladder?
Yeah.
So when the bladder is empty, the uterus goes like that. And then as the bladder fills, the uterus goes like this.
It bends?
Yeah, it can go 180 degrees. The uterus is one floppy organ, man.
The uterus is one floppy organ, man. At the end of lunch, they offered me a tour of the lab. Was I completely exhausted from taking a red-eye halfway across the country and learning more in 3 hours than I learned in a semester of college? Yeah. Was I going to turn down a tour of the lab where they're answering questions about period pain for the first time? Absolutely not. I'd take 3 red-eyes to get this tour. This tour was eye-opening, just to see how many studies their team is doing at once and how much they're learning. They showed me rooms where they do experiments with participants to learn more about how pain signals travel to the brain and what kinds of distractions interrupt that signal the best. Porn, by the way, is the most distracting stimulus, apparently. Maybe next time you get cramps, watch some porn. They showed me the MRI that all their cramp images come from. Apparently, it's a special kind of MRI machine, although those details were lost on me. They showed me a lab where they build what they called devices to use in different experiments, which I thought sounded ominous, but it turned out to just be very nerdy, kind of like a giant Lego project. The last part of the tour was the freezers. And look, I don't know if I was sleep deprived or overwhelmed by everything I'd learned that day, but I genuinely thought these freezers were hilarious.
On the corner here, you don't need to come in, but this is urine freezer number 2. I have like 5 or 6, I can't even keep count, freezers of just of urine.
Maybe it was how they were labeled. There was a piece of printer paper taped to the front of the freezer, and someone had scrawled on the paper, urine freezer 3. And then in Sharpie, someone had crossed out the 3 and written a 5. And then in ballpoint pen, someone had crossed out the 5 and wrote 3 again. Dr. Hellman's name was on it, like you would label your lunch in the office fridge. And then it said, in case of emergency, call, and a phone number. What does a urine freezer emergency look like? Melting? Leaking? At that point, isn't it too late? Okay, next up, more freezers.
This is what, effluent freezer number 2? This is a minus 80, so we keep our pads and tampons at minus 80.
With the tour over, and me clearly punchy from sleep deprivation, I headed back up to the offices with Dr. Hellman. So here we were, at the end of a day where I learned so much, including that a lot of the things I had learned before coming here were wrong, or at least incomplete. I had just one question left for Dr. Hellman. So, is there hope for menstrual pain?
There is more hope for menstrual pain than there is for a lot of other pain conditions. There is enormous hope because we know where to look. It's restricted to the abdominal region. You know when to look. And you have people that have it on some days and not on other days. You have access to the effluent, which can tell you what are the molecules involved. And there's so many people out there with menstrual pain that there's a large number of people that you can potentially study. The way science works is whatever you're most interested, you write about, you pursue funding for. And I'll be blunt, it is very hard. You got a good picture of how much effort is required to get this work done. It requires a phenomenal amount of effort, but it's profoundly rewarding. In menstrual pain, there's a lot of room for discovery.
Yeah, it seems like that. You can make some big advances in the field with one great study.
Yes. So given all these things together, if we can study these people, identify the relevant molecules, I think within 5 years, there should be some clinical trials on clearly some safe targets. And maybe in another 5 years after that, I could imagine some approval for molecules, for drugs that treat menstrual pain that do not respond to NSAIDs.
10 years until we get better drugs for period pain, huh? Was I disappointed I went the whole day without anybody slipping me a bottle of experimental drugs to take and report back on, and that I didn't become a renegade part of this research? Yeah, a little. But I guess I'll take 10 years. I got in an Uber to the airport, exhausted but giddy. Honestly, a lot of my research before coming to the GYRL lab was a bummer. Learning that we can't answer basic questions about period pain because the research hasn't been done yet, because the interest hasn't been there or the funding hasn't been there. Even though dysmenorrhea is so common, that really starts to get you down. But getting a peek inside this lab, hearing smart people talk about how important this research is and what progress they're making gave me a lot of hope. They are working so hard despite all the obstacles, and they're getting somewhere. They're figuring out how to get more funding. They're inventing new ways to test theories. They're proving that dysmenorrhea affects so much more than just the uterus. For the first time since I started making this podcast, I actually feel like we might be okay. Maybe. In like 10 to 20 years. In the shorter term, next week, we're getting into hormones. What are they? Are mine out of balance? How would I go about balancing my hormones? Why can't I escape the TikToks about cortisol lowering and hormone balancing? Would a supplement fix me? Join us next week to find out. Cramped is hosted and created by me, Kate Helen Downey. Kelsey DiLanzo is our editorial producer. Sound design and mixing is by Kelly Kramarik at Maven Post Media. Our associate producer is Katelyn Sabater. Cramped's incredible theme song is written and performed by Faraday. Our podcast art was created by Nicholas Scheppard. This podcast is supported by the Simons Foundation's Science, Society, and Culture Initiative. Fiscal sponsorship for Cramped is provided by the Arkansas Podcast Collaborative. Special thanks to Mia Lobel, Yvette Modenow, and Matthew Starr. You can find more information on the GYRL lab at cureperiodpain.org, and you can even sign up to participate in some of their studies from afar. If you want to join a community of real people talking about their period pain and sharing information, email crampedpodcast@gmail.com to get a link to our Discord. And if you, like me, were intimidated by Discord, don't be. It's basically Slack. If this podcast has been useful or helpful to you, please give us a 5-star rating on Apple Podcasts or Spotify and leave us a review. We are an independent podcast, and taking just a minute to rate and review, it genuinely helps other people find us who might need this information.
What's happening to your body? We don't know because we've never really studied the female body.